Great. So, as I said, we've been thinking about this for a while because we've been scratching our heads why patients have such, severe and life-affecting symptoms, and are really persistently seeking medical help, and yet we can't see what's going on. So we've been exploring the literature and looking for alternate explanations. And this presentation was something I gave at the European Foregut Society a while ago, just to be a little bit disruptive about putting culprits and what else might be causing reflux beyond stomach acid. So if it's not gut about bile, but in our experience, bile reflux is actually quite rare. We did a lot of studies back in the day, as we say. I'm getting on a bit now with things like Bilitech, and it was quite rare to see true bile reflux. But the concept I want to introduce today is about the fact that not all gastroesophageal reflux is equal, and what might we be missing. I want to talk about digestion and fermentation, about the process of that and the byproducts. And I'm going to introduce the concept about the proximal colon and gastroesophageal reflux as a forgotten mechanism. We're going to talk about the microbiome and GORD, and is there a relationship, and explore the concept of whether excessive gut fermentation can explain why LPR rarely responds to PPIs. Future GORD therapies, should the proximal colon be the next target? And a call to arms for refractory GORD and LPR, that we should change the way we look at these patients and try and measure different things. So fairly out there, but try and bear with me. So how to test for LPR? There's really no consensus. Should we do the same as we do for GORD? We've got here the Lyon consensus, but it doesn't really cover anything to do with LPR. So what we really need is objective testing with a twist, and we need to sort of set up a new set of parameters that give us new guidelines for looking at these patients with predominantly throat symptoms. So we can use multi-channel pH and impedance monitoring. And there are new catheters, not so new catheters, but catheters have been around about 5 or 6 years now, that actually allow you to put both impedance and pH sensors in the proximal esophagus as well as in the distal esophagus. And the way you do that is you first do a manometry, you look at anatomically where everything is, and then you can choose different lengths of esophageal catheter to get the best fit, so that when you put the pH probe up in the just above the esophageal sphincter, then you've got the best fit to keep the pH probe in the distal esophagus around 5 centimeters above the lower esophageal sphincter. And Kinesh talks about normative values. With the proximal reflux episodes that you can measure with impedance, we have established normal values. And with the pharyngeal and laryngeal reflux episodes, as he pointed out, even one reflux event into the pharynx in healthy subjects is considered, in patients is considered abnormal, because you just don't see this in healthy controls. And this is what a pharyngeal reflux event looks like on impedance. So you've got here the baseline impedance dropping in a retrograde way. And the purple that you can see on the bottom panel here is just a color plot, and purple represents low impedance, blue is gas. And here you can see red, which is acid reflux going up. And I'm going to talk about that a little bit more. And the 3 types of tests I'm going to talk about are esophageal and pharyngeal pH and impedance, the Restec acid probe, which sits in the pharynx, and just normal gastroesophageal pH and impedance. So just to orientate you to the what you're going to see, red is acidic, light blue is non-acidic pH, purple is low impedance, so usually liquid, navy is high impedance, which is usually air or gas, and the only other thing we look at is whether it goes up from the stomach or down from the mouth. So this concept of not all reflux is equal. If you've got stomach acid, which is full of hydrogen ions, it's highly ionic, what you get here is a drop in pH, strong drop in pH below pH 4. So this is around about pH 2, coming up into the esophagus. And you get a very strong impedance signal, so a dark purple pH signal coming all the way up into the proximal sensors and then sitting there. And you can see here the patients press their regurgitation button at the same time. So that's a typical acid reflux event coming up into the proximal esophagus. But we also get non-acidic reflux. So what is non-acidic reflux? It could be just a combination of diluted stomach acid, diluted with the meal, It could be potentially bile, but I think most commonly it is kind of diluted stomach acid in the postprandial periods. And what you can see here is you get a much lower drop in pH, so to about pH 5.5 or 5, and you get a weaker ionic signal here. So the impedance is still low, but it's not as low as it is with an acid reflux event. We also get gas reflux, which is blue. And so instead of seeing a drop in impedance, we see a spike in impedance. And that's usually associated with belching or transient lower esophageal sphincter relaxations. But the concept I want to talk about here is weakly acidic and weakly ionic reflux. And I'll show you about this a bit later. All of the parameters that we use for our pH impedance studies are based on measuring these stomach acid events. But if you've got something else happening, so here you can see these little drops in pH that are occurring, but nothing much in the impedance range. What we've begun to do is to try and figure out what these drops in pH are, because they quite often correlate with patient symptoms, but they're not low enough to register, and because they don't have an impedance signature low enough, they don't come up as a positive correlation. So what we've started to do in our patients is to make the sensitivity of the impedance a little bit more sensitive. And lo and behold, what we started to see is that these low, so these weakly acidic events have a weaker, but definitely significant impedance signature. And I'm going to talk about that in a bit more detail. So going back to possible mechanisms, we know that digestion and fermentation causes a large amount of bacterial activity. So what happens here, all the nutrients in the small bowel are passed through, they get absorbed. The things that are hard to digest go into the colon, and because there's lots of bacteria in the colon, then we get lots of fermentation and we get lots of goodness from that secondary metabolism of those difficult to digest, mainly carbohydrates. If you get too much bacteria in the small bowel, then that fermentation occurs much higher up in the process and causes symptoms, and that's small intestinal bacterial overgrowth. And if you get the wrong type of bacteria or you get carbohydrate malabsorption in the colon, then you get excessive gas production. I think the concept that Mark Pimentel talks about is that small intestine is a bit like your dinner plate, and the colon, proximal colon, is a bit like a waste disposal unit. So you don't want a dirty dinner plate, and you want your waste disposal unit to process things. But the proximal colon is a fascinating region. It's a bit like a second stomach. As I say, we get lots of secondary nutritional and chemical products from the breakdown of non-digestible carbohydrates in this region. It's got a rich blood supply, and it's got a rich bidirectional neural input from vagal and spinal afferents going up and down to various regions in the brain. So it's a fairly complex region doing an incredibly complex job with trillions of microbes and lots of nutrients to process. And some of the byproducts of that include short-chain fatty acids, but also gases. So things like hydrogen sulfide, methane, hydrogen, things that we can measure from breath tests. But you also get lots of other things such as bioactive compounds and volatile organic compounds. Now, thinking about pH 5 is a pH that we recognized in the proximal colon to be important. This is a smart pill stool drops off, but this is the pH in the terminal ileum here at pH about 7.9. And when it drops into the proximal colon, then we get a drop down to a minimum of about pH 5. The reason it doesn't drop below pH 5 is because at that level, bacterial fermentation arrests. And that's when you start to get a buildup of carbohydrates in the colon. You get an osmotic drive, and then that leads to bowel movements and loose bowel movements. So pH 5 is quite important, and that's what occurs due to short-chain fatty acid production in the colon. And can we measure some of these compounds in the GI tract? And this is studied from George Hanna, who's been taking to show, he's been doing work trying to look at biomarkers of cancer, but what he's been able to show is in both mixed breath and bronchial breath and in gastric and luminal air, that you can pick up all sorts of short-chain fatty acids and other products of bacterial fermentation. And there is a machine called a SIFT machine, which allows you to look at these things in real time, which will be bringing along to the BSG this year. And what we've done here, this is just me. I had a curry in the morning and at lunchtime, looked at my fermentation, and we could look just by breathing into the machine, we can look at these samples. So methane, which we're normally able to pick up, also hydrogen sulfide and uric acid. So it is possible to pick up these different products in breath. We're doing an even more detailed study now using adsorbent tubes, first of all in healthy volunteers, and then we're going to move on to IBS patients. But this allows you to collect breath samples over 10 minutes and really concentrate volatile compounds onto these tubes, and then do a huge amount of analysis to see in over 1,000 compounds what might be relevant both at baseline and in stimulated states after you've introduced a meal or a fermentation drink. And the other elephant in the room is salivary pepsin. We know that PEP test has been around for quite some time. We know that pepsin can be active at pHs below about 6. So it doesn't have to be super low for pepsin to be active. And the PEP test, which is just spitting into a tube 3 times during the day, has shown reasonably good sensitivity and specificity with pH monitoring. And 75% of patients with LPR had salivary pepsin compared to asymptomatic controls. But none of these tests are super sensitive at the moment. I think there's much room for improvement. But I think the message is there's a whole witch's brew of chemicals that aren't stomach acid that may be coming up into the pharynx and causing problems. And giving PPIs to block these compounds are not going to work. So proximal colon and GERD is a forgotten mechanism. So communication within the gut is bidirectional, and certain chemical triggers can modulate gut functions both proximally and distally to the stimulus. And a classic example of this is with fat in the distal small bowel that triggers the ileal brake to aid fat absorption. But the fermentation of carbohydrates in the colon and short-chain fatty acid production has a similar effect, and the distension from intestinal gas has a similar effect on gut reflexes. And we think this may be responsible for a different type of GERD, which is both poorly treated by PPIs and may actually be promoted by their use. So this is a study from 1996, which I certainly missed first time round, but shows some really elegant work in healthy volunteers. This is using a gastric barostat, which where you keep the volume, the pressure constant, and if the volume goes up, it means the stomach's relaxed. If the pressure goes, the volume goes down, it means the stomach is contracted. And when they put different concentrations of short-chain fatty acid as well as lactose into the colon, then we got a stomach relaxation. So the high concentration of short-chain fatty acids in the colon, you got a bigger stomach relaxation. So the proximal colon can speak to the proximal stomach and cause a reflex relaxation. And this was also correlated with breath hydrogen. So as fermentation and gas go up and that comes out of the breath, then that you get a subsequent decrease here. So what they did in these patients is to give a high FODMAP diet versus placebo diet to healthy volunteers. And what they showed is that transient lower esophageal sphincter relaxations were higher both at baseline and after meal in patients who were on a high FODMAP diet. And at baseline, the healthy volunteers had much higher baseline gas production, and it's still higher after meal. So there's a relationship here between FODMAPs in the proximal colon being fermented and effects both on the proximal stomach and on transient lower esophageal sphincter relaxations. And they did do pH monitoring here, and they showed that postprandially, there were 23 reflux episodes overall on placebo, and this increased to 35 on high FODMAP. And there was also increased symptoms of heartburn and regurgitation. And again, here it shows the reflux episodes going up in virtually all of the healthy subjects. And if this is in healthy volunteers with an intact hiatal complex, this is likely to be amplified in GERD patients. But this was very much forgotten. Now, we looked at the microbiome and GERD and if there was a relationship in patients referred for anti-reflux surgery. And this was work by Jordan from our group in Manchester. And using a hydrogen methane breath test, Jordan showed that about 60% of patients had an abnormal breath test, either for bacterial overgrowth, intestinal methane overgrowth, or a combination of the two. And overall, patients with a positive reflux association for symptoms such as regurgitation also produce nearly double the amount of gas. And this was published recently in surgical endoscopy. So there's definitely a relationship between issues with the microbiome, fermentation of carbohydrates, and reflux. So we wanted to objectively measure this a bit more. And I know ResTech has a little bit of a bad press in the past because some of the pH changes were shown actually in patients with gastrectomy. But what we saw in a lot of these LPR patients was not very much reflux during the day, but we got this nighttime drop that suspiciously sat around pH 5.5. And I inquired with the company and some experts about this, and no one could really explain what it was. And it doesn't actually show up as significant on their Ryan score, which is their kind of equivalent of Demister score, as a significant event. But being a physiologist, trying to figure out what this pH change is, it looked like some kind of fermentation product to me. So we started looking back at the pH traces of people who've had both of these tests done. And sure enough, you can see just little changes around to about pH 5 occurring quite frequently at night. And when we increase the impedance sensitivity, again, you can see the purple here, which is evidence of liquid coming up, weakly ionic, weakly acidic reflux coming up. So what we think is happening here at nighttime is that there are some regurgitation of non-acid, but possibly fermentation-related products. Now, this is one for Kinesh, that one of the things that I hear at least twice at every MDT is that this patient clearly has the SSRI deficiency syndrome. And, I absolutely know that there's going to be very similar symptoms here. No pH changes with the normal sensitivity impedance, and no pH or impedance when we increase the sensitivity. So it may be that this type of patient is the one that might respond. There's definitely no evidence of traditional reflux or this different type of reflux, and therefore, this might be a patient that would respond better to a neuromodulator, for example. So how is this different? The thing is that liquid reflux rarely reaches beyond the upper esophageal sphincter, because when liquid reflux comes up, then you trigger all sorts of vagal reflexes that protect the upper sphincter and the throat from that reflux coming up into the throat. It's a dangerous, noxious substance, and the body knows to protect against it. However, venting of gaseous reflux through the oropharynx and larynx via belching is completely normal. So when you get this type of reflux, then everything opens up to allow it to come out. And then what happens when that happens? The chemical contents of this reflux is quickly cleared during the day via swallowing. So you belch, you swallow, you clear. So you've got a defense mechanism against it. But we rarely swallow at night. So if these transient lower esophageal sphincter relaxations and gaseous events are happening at night, this weakly acidic and weakly ionic passive belch-related reflux could be driving these just get through swallows. So how do we measure them? Where's the evidence? Then, so an acid reflux event, it sits in the proximal esophagus and then gets cleared. With our LPR probe, what we can see here are these frequent weakly acidic events that are coming all the way up into the pharynx here. If we increase the sensitivity of the impedance, you can see that they're sitting in there a long time, basically because the patient isn't swallowing. You can see a swallow here, you can see a swallow here, but then nothing for up to several hours while people are in deep sleep. So a guy in Australia has taken this to the next level, and they've used reflux scintigraphy in patients with LPR. And I'm not going to dwell on this too much because this is fairly experimental, and they've not done sort of control studies. But by using a labeled substance, then they can objectively measure reflux into the pharynx and larynx using scintigraphy. And sorry. And they can actually look at this in lung aspiration as well, is what I want to say here. So you can see things, and we've all had patients who say this reflux is going into my ears, and we've kind of said, well, that can't happen. But these studies are showing that actually possibly this can happen. So just to summarize that last bit there, we think that weakly acidic and weakly ionic reflux, possibly due to dysbiotic fermentation, can be commonly detected at night with Restec and pharyngeal impedance if the sensitivity is increased. Normally, this would be vented as a belch and quickly neutralized by swallowing, but this clearance does not occur at night when patients are asleep, and the long exposure to potential irritant chemicals could be causing the problem, both in people with throat symptoms, but I think as well a big population of patients with respiratory disease. PPIs may make this worse because PPIs can often make dysbiosis worse. As shown from study with Jordan, but prospective studies are obviously needed to explore this further. Now, talking about treatment and speculating about potential treatments, then the Australian gastro we talked about here has been doing studies looking at the distended right side of the colon, and he's been treating this with prokinetics and laxatives, and some Gaviscon, but rarely PPIs. The data is pending on his study, and it'd be really interesting to see, but he's convinced that treating this region actually helps reflux in the proximal regions. This is an old study from John Hunter, and what John was able to show was that you can reduce fermentation both with treatment of antibiotics, but almost as impressively with a low fiber diet. So this is the equivalent of the low FOD. So trying a low FODMAP diet or a low fiber diet in these patients might also be a really simple way to see whether you can improve symptoms. So instead of going the whole lifestyle change, then cutting down on fermentables might be useful. And there's all sorts of other potential targets with short chain fatty acid receptor antagonists that might come out in the future if we can prove this mechanism is one that is potentially treatable. So the call to arms really for refractory GERD and LPR is to go back to your impedance files, turn up the sensitivity and assess those nighttime periods. Because if we've all got hundreds or thousands of people who've been for these studies, so the easiest thing we could do is a retrospective analysis to see if this is common, and then we can design some prospective studies. If people are doing Restec, check for nighttime drops. Don't ignore them just because the Ryan score doesn't register them. These might be important in people with throat symptoms. We definitely recommend using a general bowel symptom questionnaire. We have a questionnaire got in development at the moment. In over 300 patients referred for a hydrogen methane breath test for GI symptoms, 58% of them so far have throat symptoms as well. We think we should perform a lactulose breath test in the majority of these patients, and I really think we should try and set up a UK working group to try and explore these concepts further, which was hopefully something we're going to do through AGIP and some of the other committees with the BSG. So I'm going to leave it there and stop sharing and see.
Great. Thank you very much, Anthony. That was really insightful and certainly a lot of new things there and certainly food for thought. Any questions from anyone? Either raise your hand or type away if you've got anything to ask Anthony. Oh, I've got a question. And do you think it's practical to introduce this on a widespread basis in the NHS? Are there the people and equipment out there to actually deliver this?
Well, if we can prove the concept in secondary and tertiary care, then treating throat symptoms with, for instance, a low FODMAP diet, it might be a starting point. And if that then turns into a low fiber diet or a modified diet that people can identify triggers. At the moment, people think the triggers are things that are irritant, that might be things like alcohol or caffeine or fizzy drinks or spicy food. But actually, if that's more like garlic and onions and things, and actually the symptoms are caused at night, then maybe it's worth trying that. I think if a patient doesn't respond to diet, a bit like an IBS patient, then doing a breath test on them and treating them like a SIBO patient might also help. But if you think about the evidence that comes out about how PPIs, can lead to increased risk of gut infections, and also, the translocation of oropharyngeal microbiome into the colon, which will cause dysbiosis, then treatment with PPIs, this could kind of explain why they don't work and actually might make it worse in some people. So treating it as a potential as a microbiome or dietary related disease caused by fermentation, it's a fairly new concept, but it would be fairly easy to to treat. I mean, you know, a low FODMAP diet isn't difficult for people to try.
It's incredibly difficult for people to try. but the concept isn't difficult. The practicalities are very challenging for most people. But I accept, you know, what you say is right, of course, that it's an easy intervention.
And, you know, doing a breath test is fairly simple for most people. It could be done in primary care as well. So there's a lot of work to do. I think we just need to work on this from a kind of, you know, clinical science point of view to prove the concept. And then, you know, look at some randomized trials, which, you know, we will be doing, I think, in the next 6 to 12 months in patients with, you know, predominantly with IBS, but I think we will have to move to a kind of LPR study at some point.
And we've got a question here: are we missing inlet patches?
That's your job, Ganesh.
So yeah, I mean, I think inlet patches are certainly something that can be associated with globus. You know, no one's conclusively proved that treating them on a randomized basis actually helps. And we know that they're there for a long time. People get symptoms at a certain point of their life, and certainly there's papers showing that you can improve people's symptoms. But again, it's a bit like the PPI story. So yes, you may be missing inlet patch, but I think the firm evidence for widespread testing for that is still to be published. And I think there are a couple of trials ongoing at the moment that should help address that will hopefully report in the near future.